Hello, folks. Today I wanted to talk about pain management for those who have cancer. We'll be exploring not only what we call pharmacologic or pills, but other options, and I'm looking forward to having a good discussion with you. Excuse me. So these are some of the learning objectives that I'm hoping that we'll cover over this next 45, 50 minutes. Working, how to work with your cancer team to diagnose and treat this pain related to cancers. Understand the benefits, the side effects of standard sort of pharmacologics that we use. And then taking a look at some of the others, the evidence-based complementary therapies, as well as giving you a hint of what to expect in the next few years. In terms of disclosures, I really have nothing to disclose. I do run clinical trials with Cancer Care Manitoba. So pain is a frequent problem. We see it often in patients. Sometimes it's actually the presenting problem. In other words, the pain will present, the patient will get investigated, and that's when a cancer has been diagnosed. The symptom, the actual physical symptom of pain, is one that patients, families often say they fear the most when they're being treated for cancer. Now, we have lots of effective treatments you'll see as we work through today, but we still are not very good at assessing and treating those symptoms. And part of it is, the physicians or healthcare professionals that may not be experienced enough to acknowledge it. There may be a lack of assessment. There sometimes is a reluctance on the patient and family part to discuss it because they don't want to lose that focus about treatment of the cancer itself. There also are some issues. People worry about addiction, and we'll address that here. And it may be one of the barriers to people wanting to get good cancer pain management. In terms of the prevalence, when we look at a variety of studies that have been out there, probably between 80 and 90% of patients who have a cancer develop some pain sometime during their cancer trajectory. In other words, it could be at the diagnosis, could be during treatment, it could be after treatment is completed and we're into a palliative phase. There are, although this is a cartoon, there is some truth to this, that we can give you enough medication to get that pain under control. Well, we don't want to have other side effects or ill effects that occur because of it. Just a couple of notes to help us to understand pain a little bit more. It can be acute or it can be chronic. Chronic is usually if it's been around for about 3 months or more, so if the patient has been experiencing it. Nociceptive or more somatic. In other words, it's more due to structures as opposed to the involvement of nerve, which we call neuropathic. Previously, we thought that cancer pain was really just because there was some tissue injury, there was a lump, there was cancer sitting on either a bone, a muscle, an organ, or a nerve. However, when we look at it, it seems that it's more complex. So there's molecular mechanisms, there are some neurobiological changes that happen because of the presence of the cancer. There's pain receptor stimulation, as well as the involvement of inflammatory factors. When you're meeting with your cancer pain team, it's really good to help them understand what that pain sounds like. And certainly when people come to see us in our pain and symptom clinics, we ask them these questions. What does it feel like? Does it stay in one place? Does it go elsewhere? What are some of the descriptors that you can talk about? So is it localized? Is it sharp? Is it kind of vague and crampy? Is it kind of there and not there? In other words, transitory? Or does it come with very specific movements or at very specific times of the day? Cancer pain is often worse towards the end of the day and into the early evening and night. Some people will describe pain as being burning, tingling, stabbing, electric shock-like. That gives me the sense that this might be part of that the nerves may be a part of it, or there may be some direct invasion of the nervous structures. When there's changes in sensation, sometimes the non-painful stimulation, like a brushing against the skin, gives you a pain. That is a sign that there is definitely some changes that are happening in the nerves, and we'll need to take some action. Now, when we're talking about pain, there is this concept that pain itself can be affected by one's emotional and psychological state. When a person is depressed or they're more anxious, they tend to rate pain as more intense and more disabling. And you can see here that there's a patient and family issue that can affect the source of pain. There may be emotions that are that are playing a role in this. There may be a history of patients with more chronic pain, or they may have a history of seeing their family member having pain. And then there's things like, what do we as healthcare professionals contribute to this area? So really, when we're talking about total pain, we're often talking about suffering. And this can be a very big problem for not only patients but families, and this can be uh, continued through different treatments if we're not attentive to it and we're not addressing it. I think it's really important when we do an assessment regarding pain, we take a history. We want to know more about the pain itself and just some of the issues or some of the things that we talked about in terms of pain descriptors, how long it's been there, what has been the experience with medications that have been given to them. Um, Doing a physical exam will help us to isolate the area that's of concern. Imaging may be helpful. Sometimes the imaging is already done. I don't need to ask for anything more. But sometimes patients will say, it's right here. Nobody has really addressed this area. And that's where doing something like an MRI or a bone scan can be really helpful for us. I always talk to patients about doing some blood testing because it's important to know what is the function of your body. What's the liver doing? What's the kidney doing? Often these things are already assessed because of the function or the need for chemotherapy. But I also want to rule out infection because an increased white count might lead to discovery of an infection. Treat the infection, the pain suddenly gets that much better. In terms of assessment, it's really good for us to have an idea of the intensity of the pain. This is an example of what we call the compass. This is a form that we ask people to fill in when they come to see us in the clinic. And you can see that it has a number of numerical rating scales, the ESAS as it shows there. They describe the pain as 0, no pain, to the worst possible pain, assigned a number of 10. We also do this in conjunction with all these other symptoms because these too can lead us to ask more questions, but also if you are truly depressed or anxious, that can affect the way that we would address and treat the pain. Now, we do have an electronic method of communication, and Nuna can help us if there's pain happening at home. This can be communicated to us, the team there. Now, one of the things that I think we should address very early on is the issues around addiction and tolerance if we're going to be using certain medications. Certainly, opioids are a mainstay when we're talking about patients who have cancer pain. And there's a perception, and some of it has been fed by the media, some of it fed by people who may not be aware of the actual functions or the biochemical mechanisms behind it, that when you start taking an opioid, you will become addicted. And it's just not true. Addiction, substance use disorders often have complex factors. There's usually issues that we see present before the opioids are used. So people already have evidence of some sort of substance use issue, or they may have things like a gambling addiction, and that will predict for issues with substance abuse. So one has to be aware of this before we start. There is what we call a dependence, though. As you start using the medication, your body becomes a little bit lazy. It won't necessarily produce its own natural pain relievers, the enkephalins and endorphins, and then the cell receptors, those that help us to feel or perceive pain, can change. The tolerance, in other words, if I give you a dose of one tablet and it seems to work for your pain, but 2 weeks later we find that we need two doses, that's an example of tolerance. Your body says, well, this is enough for right now, but sometime in the future, it might need a little higher dose in order to get the same sort of pain relief. Addiction itself, as I said, it's kind of complex. It's not only behavioral changes, there is some psychobehavioral changes, the impaired control over the use of the drug or the compulsive gambling, for instance, compulsive use. There's a craving. You have to want to, not only do you want the drug, you want it, you crave the effects, the psychological effects that happen with it. And then, even despite harm, maybe even the knowledge that this use can become problematic, it's very difficult to stop. Pseudo-addiction is another issue we see not uncommonly in cancer pain management, where it appears that the patient wants more and more pain medication, but it's just because we haven't been able to achieve that level of pain control. They want to have better pain control, so they are often asking for an increased dose. And this comes again from some experience with the healthcare professionals that, starting with one dose of medication does not mean that that's the dose that's going to fix all of the pain. Oops. Now, when we talk about the treatment, the spectrum of medications, physical modalities, other sort of modalities to help out with pain, you can see that there's quite a wide range of modalities. What I want to do today, start off today with the treatment around the pharmacologic. They're fairly simple and straightforward, and then we'll go on to some of the other areas. So often what we are talking about is the use of pain medications. We talk about morphine or members of that family. However, I think that we need to be aware that even mild pain can be bothersome to people, and we don't need to go to some of those really intense or strong opioids right away. We can start with acetaminophen, Tylenol, the pain reliever, and Tylenol. Really, we're talking about starting off at a dose of maybe 1 gram 3 times daily. That can be increased if you're a younger person. If you are about 70, 75 and older, we generally say 1 gram 3 times daily is the limit. There are anti-inflammatory medications, what we call non-steroidal anti-inflammatories, things like ibuprofen or Advil, naproxen. These are, again, pretty effective in those types of cancer pain where inflammatory factors are involved. There are some known side effects. So if we're taking too much, or if you already have some stomach upset, maybe this isn't the best one for you. And this is where I really like to hear from patients when they say, can I take this? And then we can assess that right there. So when we talk about opioids, there are a number of different ones that are available in Canada, and they range in strength or intensity. So if we take a look at the potency, codeine as part of a Tylenol 3 can be quite effective for some patients. Remember that codeine in the body is transmitted or sorry, is changed into morphine. So when we're talking about codeine, it's about 1/10 as strong as a morphine tablet. There are other medications that have now been developed, tramadol as part of Tramacet, tapentadol. These are what I would call low potency opioids. And they do have a bit of a limit. You can't really go beyond a certain number of milligrams of these. Morphine, oxycodone, hydromorphone, even the fentanyl patch is probably the most common group of opioids that we're given. Morphine, as I said, is very strong, but things like oxycodone, about 1.5 to 2 times stronger, hydromorphone, about 5 times stronger. Fentanyl, milligram per milligram, is about 100 times stronger than morphine. The fact that it's available in a patch makes it much easier to use. The third line, or what I would say advanced medications, are whoops, these that are methadone, fentanyl injectable, sufentanil injectable, as well as buprenorphine. These are ones that need experience. This is where I do suggest you seek out pain and symptom management. My colleagues in palliative care also have good experience using these. Remember that opioids do have side effects. Some of these are due to the effects of the opioid on different cellular receptors. So constipation, nausea, it tends to affect the GI receptor, slows down the bowel. It can cause some dry mouth. It can cause some urinary retention in some people. As the doses get higher and higher, you may experience some drowsiness. You may find that people have more troubles with memory. This is a sign that we need to reassess things, see what if we're using too high a dose or maybe the wrong medication. We do have other options, as you see there. And some of the things that we can do, include reducing the dose, switching the opioid, let's say from morphine to an oxycodone or something, switching the route of administration. If the nausea is quite disabling, we might go to something like a topical patch. And then, of course, if you have constipation, we often will be using some form of laxative to help out with that. In addition to opioids for cancer pain, we also have a number of other therapies that are somewhat targeted. In other words, they have usefulness in things like bone pain, different types of somatic pain, neuropathic pain. And these are drugs because they emulate some of the neurotransmitters. This is what some people will feel that can be very helpful. They often are not strong enough to treat the pain all on their own. And sometimes we are kind of mixing and matching. Sometimes we're using them in conjunction with an opioid of some sort. And you see that they belong to a number of different families, such as the antidepressant family, the anti-epilepsy medications, the N-methyl-D-aspartate receptor agents. These include ketamine and methadone. Cannabinoids, we'll talk a little bit more about those in a moment, but there are a number of cannabinoids that we've found that can have some effect on cancer pain. Steroids, in other words, an anti-inflammatory, can be very helpful in short-term bursts to help out with some pain. And patients who have bone pain, especially when it's combined with some form of cancer, let's say, for example, myeloma or breast cancer, bisphosphonates are now a standard of care to help reduce the pain. The next area that we want to talk about is some of the physical. What are some of the activities that one can do to help to reduce some of the pain that we're talking about? So some of this is really because if you have, let's say, bone pain, you want to improve the muscle strength because those muscles are helping to protect the bone. So, if you are undergoing chemotherapy or treatment and you're feeling quite good, you have quite a lot of energy, even things like walking or cycling, if it's a little bit less impact, if you will, can help to not only increase your energy, but also help to protect against some of these painful issues. Having physiotherapy, stretching, having some passive movements of the muscles can be very helpful as well. We also talk about if there is, a problem with impact. We say aqua fitness is a good option. This way you actually take the weight off of the body or off the legs and things, and you can get a fairly good body, a total body workout. Certainly weight training, and I don't mean like bench pressing 300 pounds, but rather even just using small weights, whatever you have at home can be very helpful. Massage has been shown to be effective in some areas. We also know that Pilates can be helpful with some, again, increasing the energy, the increasing the mobility, and the flexibility of people who are undergoing treatments such as chemotherapy. In terms of People who may have a low activity level, we can be looking at more passive stretching, having physiotherapy or physiatry involved to help out with this. Transcutaneous electronerve stimulation has been used and has been helpful in terms of reducing pain. Yoga, acupuncture, massage have all been used for patients who have pain. And these are movement modalities that are complementary to what we offer. And actually, they've been shown to be somewhat effective in reducing pain. We'll talk about that in just one moment. The next area, and I think that you've heard a little bit more about the use of psychosocial or counseling, trying to help with those areas, that depression, that anxiety that often comes with cancer or the diagnosis of cancer. It can, if you will, focus that pain and make it that much worse. So the intensity feels worse because of the presence of these areas. Certainly, things such as counseling, talk therapy, cognitive behavioral therapy, different types of psychotherapy have been shown to help reduce pain, help, with other sorts of modalities, especially if we're talking about opioids. One may feel that they don't want to take as high a dose, and using the services of our psychosocial group, we can actually develop and reduce the pain for patients. These are some of the modalities that are out there, some of the things that have been developed over time and have been shown to be beneficial through clinical trials. So, meaning-centered psychotherapy, calm therapy, which was developed out of Toronto, specifically Princess Margaret, dignity therapy, again developed out of Manitoba here by Dr. Harvey Chachanoff, has been used by many practitioners. And we do see that people have decreased pain intensities after they've undergone the therapy. And then mindfulness-based cancer recovery. Again, this has been developed out of a number of centers. The University of Calgary and the Calgary Comprehensive Cancer Center have really put this forward and have been working very hard to show the benefits of this with patients who have cancer. Now, the last area I want to talk about, looking at this spectrum, would be the surgical interventions. And usually these are because of either tumor that's affecting the bones directly, have an effect upon nerves. They may even be, let's say, a tumor that's developed in the muscle and needs to be removed. This can be very beneficial. And this is where we're talking to our surgical colleagues about getting in and doing the work. And I think it's very important for us to look at this, determine that it would be an option early on so that you can actually get benefit out of it. Some of the different procedures include things like spinal stabilization if you've got disease in the back, repair of a fracture that may be there because of the presence of cancer. And then, excuse me, the use of hardware such as having metal plates or pins to prevent that fracture from becoming looser, causing more pain. You want that stability. Radiation has also been very helpful for things like bone-based cancer pain, neural-based cancer pain. And this is just a cartoon showing, one person's perception of what it's like. And we know that this can be effective in up to about 80% of patients who receive palliative radiation. One of the things that's really important in terms of pain is monitoring. So I can give you a pain medication and say, let's see how this works. We'll call you in 3 months. That's not good enough. Especially when we're starting a new medication, it's really important to know what's that dose? Is it the right dose? Have we found is a medication starting to interact? Are you having side effects from the medication that it would actually limit your ability to take it? And this is really important within our pain and symptom clinic. I work with a wonderful nurse, and either myself or the nurse usually gets in touch with the patient after 3 to 4 days to find out how things have gone. When we see patients on a Friday, we're often on the phone by Monday or Tuesday to see what's going on with that. Certainly, we've used things such as a pain diary. We've employed the digital program Nuna that has been really helpful. And something for you as a patient and family to know is that there's always an on-call medical oncologist, hematology oncologist, even a radiation oncologist, accessible 24/7. So as we're speaking, I know one of my colleagues is on call and monitoring and taking phone calls, trying to problem solve any time of the day. So one of the things that I suggested we were going to talk about was about plants. And one of the most, if you will, common plants that we use for pain control is the cannabinoids. And we in Canada are somewhat fortunate in that we have access to cannabis both as a medical option as well as a recreational option. And for those of you who are unenlightened, if I can say that, this is a cannabis plant. This is actually a particularly good cannabis plant. You can see that there's a number of these little nubbins that are on there. These are called trichomes. And within those trichomes, and this is a highly magnified area, you can see that there's this cavity, and that's where the gold is, if you will, the Acapulco gold. This is where the cannabinoids are concentrated. This is why when you see a plant that has a number of these trichomes, you know that you're getting a good harvest, if you will. This is just a glossary to keep you to let you know why I'm calling this cannabis and not marijuana or medical marijuana. Marijuana is a bit of a pejorative. It was developed because people of Latino descent were seen to be using this in the early 1920s, and they were vilified for that. And in fact, the FBI moved forward with making cannabis illegal because of this sort of area. Now we know that there are a number of different species. Indica and sativa are the two that we hear the most about, but most plants that are grown in Canada, whether for recreational purposes, for medical purposes, are a hybrid of the two. There's been a development because we're looking for a specific type of cannabinoid that's in the plant. You may hear about hemp. This is a cultivar that does not have THC or has a minimum of THC. This is actually a cash crop because hemp has a number of different uses, commercial uses outside of the use in medical. And as I say here, the THC, CBD, these are the main cannabinoids that have been studied. Cannabidiol, tetrahydrocannabinol have been studied in a number of different areas. We'll go through those in just one second. But I also wanted to bring up that there's a number of other components that are within the cannabis plant, and especially when we're developing this as a medicine, you'll see that we can bring into place a number of these other non-cannabinoids and cannabinoids. When I did this presentation a number of years ago, I would have one psychoactive called tetrahydrocannabinol. I would have one non-psychoactive. However, the playing field has enlarged. There's lots of other cannabinoids that have been isolated and are used clinically. Terpenes are an important part of the cannabis plant, which is also an important part of many plants. And this is what gives the plant an aroma or a flavor, and they describe some of that here. So citrusy type flavor comes from limonene. Something like eucalyptus or a spicy flavor come from the eucalyptol. And these may have effects all on their own, but otherwise they work together as part of the entourage effect of cannabis. One of the thoughts we always have, or one of the questions we have is, why does this work in the first place? It's because we have a well-developed cannabinoid system within our body. This includes receptors such as the cannabinoid 1 receptor, the cannabinoid 2 receptor. There are products or neurotransmitters within our body, anandamide, that attach themselves to these receptors and have activity. And then, of course, there are different enzymes within our body that create the products, the endocannabinoids, as well as break them down because we don't want to have a constant exposure to the cannabinoid because that might cause other sorts of problems. When we look at what Canadians use, and this is really important because we do have access to these products at the street corner because every street corner happens to have a cannabis shop. And you can see that the number one issue for patients is often insomnia. But if you look at this, acute pain is about 17%, chronic pain is 33%. So that works out to about 50% of the time patients are looking for cannabis to help out with their pain. Anxiety, as we talked about, depression. They don't talk about cancer here, but these are symptoms related. Often these are related to the presence of cancer. This is an important slide just because you see that there has been a change over the years. We've had access to cannabis in both recreational and medical products since about 2017, 2018. And you see that there's a decrease in the amount of use of leaves, in other words, the dried flower, the products that you use for smoking or for vaping. And there has been an increase in things such as edibles, certainly some topical products, and then things such as oil or beverages. The beverages you can see here has increased about 10% over that same period of time. So again, when we're talking about medical cannabis, what's available to us in Canada, these are the types of things that we can have access to through the medical program. So again, if you really feel strongly about smoking, we can get dried cannabis, we can have extracts, gel caps or capsules. Edibles are available. I just saw on one of the websites they were selling cookies with so much THC in them. Many people are using vapes instead of smoking, and the vaporizer cartridges are safe. These have been passed through Health Canada and approved for that. People often ask, well, what's the dose? What should I be using here? And this really is kind of an individualized dosing. You know, it depends a little bit on your past use. If you've been a regular user of cannabis, of let's say a recreational or even medical, that makes a difference in terms of the product mix that we would be looking at. We also know that if people are taking it orally, it will last longer than people who are inhaling it or using it via vape, just because of the increase and then the very short half-life of a vaped product. Cannabis can have some euphoric or some high. People can feel high because of it. It also has been linked to things like psychosis. People who already have schizophrenia shouldn't be using cannabis. This can actually bring on further psychoses. People who have unstable heart disease, we know that this can actually speed up the heart rate. It can cause, if you have some angina or heart already, pre-existing heart disease, we suggest don't do using high dose cannabis. People who are already on oxygen probably shouldn't be smoking or vaping. That's a bit of a danger thing. We could be looking at things like an oral or an oil, and that would be all right. Again, pregnancy, breastfeeding, this cannabis and the products would be transmitted directly to the baby, so we advise against it. Because this is a plant, some people do have an allergy to the specific cannabis plant, the indica or the sativa. There was an issue at one time about age. How old is old enough in order to use cannabis? People were worried about the development, the development of the brain, the nervous system in young people. This can actually continue up until our mid-20s or so. So exposing someone to that at a young age may cause some delay or some changes. But there is ongoing controversy about this in the literature. Like any medication, there are some side effects that are associated with this. So things like dizziness, disorientation, drowsiness. This is often due to the high dose of THC that one gets with this. Um, Diarrhea, euphoria, confusion, again, often related to the higher doses. And it's really important when we're starting that we start low. We start at a low dose and then increase according to the needs. And again, this is where sitting down with an expert in this would be really helpful for patients. And just to let you know, in terms of cancer, what are these sort of symptoms that are responsive? Certainly, we know about pain, muscle spasm. We see that quite often. Patients who have muscle spasm due to something such as multiple sclerosis may get some benefit from the use of cannabis products. We also talk about using this, or there has been more research looking at this for patients who have painful neuropathy. And some of this is due to our chemotherapy, and there has been other diseases associated with painful sensory neuropathy. Is this an effective treatment? There's been lots of literature, and now there's actually some studies looking at that. This is a study that was published just recently. 40 patients were using a topical CBD. This was isolated. There was no THC in this. The study product was applied for a couple of weeks, but unfortunately, it did not support that this single agent, this CBD alone, could establish CIPN, or chemotherapy-induced peripheral neuropathy. We do know, though, there has been a number of observational studies that patients who have used cannabis previously seem to have less onset or less risk of developing chemotherapy-induced peripheral neuropathies. At this time, I'm helping to run a trial here in Winnipeg. This is a national trial using a product that's called trichomyelin. And as you can see here, it contains THC, CBD, and CBC. All of these are components that are well known to work together. THC has been shown in many areas to decrease cancer pain. So this is something that if you're interested, if you have not used cannabis for about 4 weeks beforehand, you may be a candidate for this. And this would be something that I would say bring up with your team, or you can even contact me directly about that. So it's really important when we're talking about pain management not to disregard other areas. So some of the other complementary areas that are out there, including integrative medicine. And the definition of integrative medicine, an approach to medical care that recognizes the benefits of combining standard or conventional therapies with complementary therapies. And we've already alluded to this using things like acupuncture and yoga that have been shown to be not only safe, but effective. And if we take a look at some of the studies that are out there, you're talking about acupuncture, yoga, massage, and these have been shown to be beneficial in some of these very specific areas. So patients who have breast cancer, chemotherapy-induced peripheral neuropathy, hypnosis, and music therapy has been shown to have some benefit, although the strength of recommendation is not as strong as you'd think. And then they find that there's not enough evidence to help support the use of these sort of modalities in pediatric pain or radiation treatments. This is just another way of showing that. The evidence in green has an intermediate quality of evidence. The recommendation is moderate. If it's blue, the quality is quite low, but there's a moderate recommendation based on the research that's been done. And then those that are red, low quality, weak recommendation, it often means that there hasn't been quite enough research to support that. Couple of other plants that I just want to touch on at the moment. These are kind of on the tip of the research areas. So we talked about cannabis, but then capsaicin, or the active ingredient in hot chili peppers, now has been, there's been a molecule that's been developed out of those called RTX, and I'll show you just that in just a second. And then the effects of what's in mushrooms, especially the psilocybe cubanus mushroom. So RTX, this was a fairly recent publication looking at the use of this. This is as I said, a ultra potent analog of capsaicin. It is very specific against a receptor that we call the TRPV1. And this was very basic sort of studies that have now been extended to patients. And we're seeing that there is a hint of the benefit here. We'll be keeping our eyes on this because I think that this will be beneficial for us in about 3 to 5 years. In terms of mushrooms and other psychedelic medications, interestingly, a number of these psychedelics mimic a naturally occurring neurotransmitter. So these are things that could have some definite benefit to our patients with its use. Of course, supervised use and through clinical trials is the way to go. A little bit of a study that came out a couple of years ago just gave us more information. Certainly, a review of the use of LSD or psilocybin has shown that there's been some benefit in things like cancer pain, phantom limb pain. And this is something that we're going to be exploring in the near future, as I am part of a national group that's developing some studies to do this. And lastly, I just wanted to mention that there are these herbal remedies for pain. These are more, I would say, complementary alternative. These are things that have been recommended. And you see that there's a large number of these that have been put forward. None of these have really been used in cancer pain. I haven't seen any sort of clinical trials, randomized control trials to show that there's been some benefit to these. And I would not use these on their own. I would use these in conjunction with the more standard approaches. There are some people who will find that this is going to be very beneficial for them. And certainly, when I'm talking about topical pain medications, I often use things like menthol to help emphasize or increase the efficacy of the medications that we use. Couple of other things, and again, this is purely study. These two toxins, one developed from a pufferfish, the other, of course, is Clostridium botulinum or Botox. Both of these have been used in studies to show that there has been a reduction in cancer pain. Again, are they strong enough to work on their own? Not quite. So, not quite ready for prime time yet. My take-home messages. It's really important to know that cancer pain requires focused assessment. We can certainly effectively treat cancer pain. I would say that we're probably effectively treating 90 to 95% of patients with the kind of wide range of treatment modalities. We bring in some others and we're able to increase that rate to a little bit higher. I think that we need to be aware of and start including these integrative approaches that can be more comprehensive for patients who have pain, who have cancer pain. We know that patients are seeking this out when they don't get effective relief from just the pills, and that's really important. And of course, I think research really holds promise of these new, really exciting therapies that are coming up through the pipeline. And I'm happy to take any questions that you have.
Wow. Dr. Daeninck, thank you so much. I'm not sure if you could see the applause emoticons there. Such valuable information and breaking down such a huge topic of pain management in such a short amount of time. And so I'm looking to see if there are questions. I don't see the feed, but I'm sure there are, Dr. Daeninck. One sec here. First one, I have been going to an acupuncturist before treatment and during, and now post-treatment, I am more sensitive to pain. Should I be concerned?
Probably not, no. I think your perception of pain is heightened because of the treatments. Remember that when we're talking about acupuncture, you are accessing a different form or a different level of sensitivity to pain. I think it's important to bring that up with your team because what we might need to do is just adjust the dosage of other medications. But I don't think, if you're finding the acupuncture to have some benefit, don't stop.
Okay. Taking Tylenol and Advil together, is that okay?
Depending upon the individual, we sometimes say that. We do find that some people respond to both, or what we would do is maybe alternate the dosing. Tylenol first thing, 2 hours later, we can take something like an ibuprofen, and then just kind of alternate through the day. There are some people where that alone keeps their pain under control.
Absolutely. And last question here, Dr. Daeninck. Is cannabis a good choice for relieving joint pain?
Haha, very good question. And this is one of those questions that we in the cannabis space have been kind of dealing with for a while. We know if there's an inflammatory component, that use of THC plus CBD can be very helpful. There are some people who postulate that the higher the dose of CBD, the better the treatment for inflammatory type pains. If we're talking about someone who has, let's say, joint pain secondary to the treatment, let's say, we use some of these aromatase inhibitors and that's causing some joint pain. There's not a whole lot of evidence on that yet, but I know that there's at least 2 studies that are starting in the United States that will help us to answer some of this question. Some of it is going to be based on are we getting the dose right? Are we using it effectively? Are we using the right cannabinoids? So, THC with CBD, with CBC, these are the questions that we're going to have to work out.
Absolutely. Wow, Dr. Daeninck, never enough time. Thank you so much for again breaking down such a big topic for us and for our viewers who took the time to, yes, field your questions into Dr. Daeninck. So thank you again for being with us.